Hello, welcome everyone. This is Level-Headed Mind. My name is Giselle Rosa. I'm a psychiatric nurse practitioner. As you guys are coming in, please let us know where you're listening from or watching from. And if you have any questions about mental health care, please drop them in the comments section below and I'll be happy to answer your questions. A little bit about me. I'm a psychiatric nurse practitioner since 2021 and I've been a nurse since 1999. So I was a nurse for quite some time before I became a psychiatric nurse practitioner and became an integrative certified nurse practitioner in 2022. So most of my focus is in integrative mental health practices and also with reducing harm, and therefore I have the skills before pills approach. As you know, in my videos that I talk about with mental health care treatments, different medications, and various topics, I always like to emphasize the skills before pills approach because, as you know, with medications there are lots of risks that can occur, not just side effects, but long-term effects and emotional numbing and potential withdrawal issues and protracted withdrawal that can occur with these types of medications. So we have to keep that in mind when we're talking about mental health care treatments in general. So it looks like we've got 10 people watching here today. So if you have any questions, go ahead and drop them in the chat. If not, I know Raul is working in the background with me. He is Perion, and he actually will have some questions that were not answered in previous lives that I could start answering now for you guys if you guys don't have any questions. Okay, so looks like MDP Lady had asked prior, what are your favorite resources to learn more about how our neurotransmitters work? I have a lot of resources that I use. Obviously, all of these books back here are resources, but my favorites are Dr. Greenblatt's book. I'm actually in my second year of fellowship with him, but Nutritional Lithium, Antidepressant Withdrawal. That book is very, very helpful. His book on depression and integrative medicine for depression is also very helpful. I also do read Carlot. Carlot books are mainly focused on medication and like taking snippets of the highlights of the FDA label. So that's always good to know and review. Stahl's, I have his psychopharmacology books, both the 4th and 5th edition, and also his deprescribing books. I think I have 3 of those now. And those books kind of help give guidelines when you're prescribing. And then the Maudsley deprescribing guideline helps with deprescribing. That book just recently came out in March of this year, actually, which I'm glad to see that we are moving more towards understanding how to deprescribe these medications safely, because originally what we were taught can actually be harmful for many people if you remove these medications too quickly. So yeah, those books, journals. I also listen to, let's see, the APNA, American Psychiatric Nurses Association journal. And I also listen to podcasts like the Carlot Psychiatry podcast. So they have their reference books, but they also have a podcast that I like to listen to. Rebel Health Tribe is a really good resource online for education on holistic approaches to not just mental health, but other conditions as well. And he also has Michael Rosengren also has a podcast that I like to listen to that just came out a few months ago. So yeah, lots of resources out there, and those tend to be the ones that I go to more frequently. With YouTube, I do like, of course, Dr. Tracy Marks and Dr. Huberman. As resources. And then the tapering expert is Dr. Yosef Witt-During at the Taper Clinic. So those are, I guess, my top resources. Hello, can low-dose aripiprazole and modafinil be used together to treat depressive and negative symptoms seen in schizophrenia? So with the negative symptoms in schizophrenia, what you're talking about here is like the blunting affect, the cognitive also type of dysfunctions that occur with schizophrenia. And oftentimes, this can also not just be caused by the disease schizophrenia itself, but also can be exacerbated by some of the antipsychotics, especially the older generation that are more dopamine blocking. So aripiprazole is a newer, like a second generation antipsychotic. It has partial agonism on dopamine. So what that means is it's not going to turn it down too much. So it's going to modulate it to help. And using modafinil. Now, modafinil is a norepinephrine and dopamine reuptake inhibitor, so it's actually a stimulant. You have to be careful with using this type of combination treatment, especially with schizophrenia patients, because it can induce psychosis. So if these are being used together to treat depression and negative symptoms seen in schizophrenia, I would be very, very concerned on the dose of modafinil that's being prescribed and the timing. So making sure it's early morning and maybe just doing once a day dosing versus twice a day. And also keeping the dose very low because of that risk of inducing a potential psychosis. So aripiprazole could work just because of the modulation of the D2 and not being a complete blocker there, which could, like I said, oftentimes create this negative symptomology that's often seen with schizophrenia. So I guess, yes, it can be used, but it must be used with caution and used under the direction of an expert, like a psychiatrist. Corey McDonald, hello. I have anxiety. I have tried a lot of antidepressants and nothing helped. I felt very wired and or strange feeling, just off feeling. What can I try next? You've tried a lot of antidepressants and nothing has helped. Well, I don't know if you've looked into a GeneSight test, or GenoMind is my preferred over the two. But that could kind of give you an idea of why you're not responding to a lot of antidepressants, and then kind of give guidance on which medications maybe you would respond to based off metabolism. Oftentimes when you're not responding to a lot of antidepressants, it may have to do with some pharmacokinetic, like the way the drugs are metabolized. So like your CYP enzymes, maybe perhaps you're a fast metabolizer, metabolizing some of those enzymes too quickly, like that pathway too quickly. So some of these medications aren't useful, or maybe too slow where you're just getting side effects instead of the benefits. It could also be some pharmacogenomics where maybe it's the actual serotonin transporter gene that's the issue, where pretty much none of the antidepressants or those medications that use that transport system would be helpful if you have the short allele of that version of genetic expression, so to speak. So it would depend on several things. Now, when I think about someone who has anxiety, my first thing is not going to medications. My first thing is figuring out what's causing the anxiety. So going back to our skills. So it's recognizing what's triggering the anxiety and recognizing what our symptoms are. So doing things like journaling when you have anxious episodes, figuring out what you were thinking prior, what was going on during the anxious episode, what you did afterwards can be helpful to see if there are patterns, and then exploring your body sensations. And you can do this just by being present in that moment, doing like a body scan to figure out your sensations, because everyone's warning signs for like an anxiety attack or panic attack are going to be different. But once you tune into those warning signs and you recognize that, hey, I start to clench my jaw right before I start to get very anxious, and you notice it, then you can start working on down regulating that response. So maybe start doing some vagus nerve exercises and getting the nervous system calmed down. Maybe it's some diaphragmatic breathing exercises. So it just depends as far as what's causing the anxiety, etc. So I would want to get into therapy and develop some of these skills to recognize what is causing the anxiety. And then the other way I would look at this is maybe we're looking at some nutrient deficiencies, or maybe there is a genetic propensity. Maybe you're not metabolizing your B vitamins properly and you have like an MTR, MTRR, or MTHFR gene expression, which can be identified in genetic testing. But also with lab testing, if we find elevated homocysteine, we could be very suspicious of that, along with checking your B vitamins, particularly B12 and B9 in serum levels, and then looking at other nutrients, magnesium, your omega-3s, what are your inflammatory markers. I do have a video that goes over the basic labs for mental health, which could be helpful to kind of help you and your provider get started on that path. If we're just going to go directly into anxiolytic medication, alternatives to use besides antidepressants while you're trying to build these skills could be things like hydroxyzine, propranolol, or clonidine. These have a lower risk of dependence and tolerance issues as other anxiolytics or antidepressants have. And I do have videos on those types of medications. So you can check those out if you're interested in that. But I would certainly want to work on the skills aspect of things, figuring out what could be the root cause of your anxiety and fixing that, because you could avoid medication altogether if you can get down to the bottom of it. Claire Lampus, hello. Thank you for your videos on MTHFR and COMT. I was feeling so in a rut and took a pharmacogenetic test that showed that your MTHFR, C677T, and slow COMT. Oh boy, yeah. Getting the right B vitamins on board has been life-changing. Absolutely, yeah. This combination is actually interesting. And I think that, so what she's saying is she's heterozygous or CT. There's another variant, AC. So sometimes you could be compound heterozygous, which is more. But with the CT, I think you're maybe 30%. So maybe you're getting about 60-70% of the folic acid, like breaking it down. So you have a 30% deficiency. With the slow COMT, you're probably talking about being met. So this combination here, a lot of people are going to be very, very anxious. So that person that's talking about medicines aren't helping me, et cetera, et cetera. Maybe you have something like this going on where B vitamins and the methylated, or some people can't tolerate the methylation now. And I don't know if this has been the case with you, Claire, but when you have the slow COMT and then you start upregulating the MTHFR, which means like you start now providing methylated forms of your B vitamins, you can actually increase that methionine cycle and dump it into the SAMe. So how you S-adenosyl methionine and then COMT, the way that those catecholamines are broken down and recycled, yours is slow. But because you're upregulating the upstream process of that can create more dopamine, norepinephrine, epinephrine, more anxiety. So sometimes those methylated B vitamins may not be the best, and you may want to do like methyl-free B vitamins like hydroxycobalamin and other forms. And Seeking Health, I believe, that's the brand I think off the top that has some of those. But certainly, yeah, just be careful not to overdo it, because you can certainly see improvements in the breaking down of your B vitamins and then improving the process of breaking down the COMT. So sometimes SAMe is also needed for that process as well. Jiminade, hello. Why do some people on ADHD meds report elevated anxiety while some report relief? This is very interesting. And Jim is a channel member, so I'd like to say thank you for being a channel member. And just remember, if you're a channel member, you do get priority answers to your questions, as well as, of course, super chats, etc. But otherwise, I'll go in order. So Jim, thank you for being a channel member. Some people with ADHD will report elevated anxiety because oftentimes there is a lot of cross symptoms that are interrelated between anxiety and ADHD. So either it's a misdiagnosis and the person doesn't have ADHD and now we just exacerbated their anxiety, or it is a combination of the two. And when you have a combination of the two, you treat anxiety first. If it's just a pure ADHD presentation, those stimulants are actually going to help the person to calm down because it's enhancing focus and concentration. So that's where those people get a lot of relief, and they'll actually tell you the stimulants make them calm. So it has an opposite effect on someone who's already anxious and has their norepinephrine, adrenaline, cortisol high because of anxiety, and now you give them a stimulant and you increase that cycle, they're going to be very, very sensitive to those stimulating side effects and end up with more anxiety. Another thing to keep in mind too is a slow titration of the dose. So even if you give someone who has true ADHD a stimulant, if you give them too much, you could cause it because it can be a side effect. So you always want to do a slow titration just to see what dose will help them. But oftentimes, even just a small dose, starting initially with someone with ADHD, they'll notice like a calming relief type of feeling and able to focus and concentrate and get their work done, etc. Whereas those with anxiety, you start them with that little dose and they will completely go into panic mode and high anxiety state. So that's typically what happens there with patients who are prescribed ADHD meds. Thanks for the question. Daniel Duran, hello. Is kombucha a good thing for gut-brain function? So yeah, kombucha is very helpful because of the live microbes, that the fermentation process and the microbes that are in kombucha. Now, it is also caffeinated, so you have to be careful there. But if you don't have anxiety and you're not worrying about the caffeine aspect of things, and you're looking for a boost in maybe motivation and energy and things of that nature, then yes, kombucha can be very, very helpful in boosting memory, cognition, and energy. Plus, it does have those microbes. Now, I want to say something about this. Some people will think of kombucha as a probiotic, but really, once you and other foods like yogurt and kefir and kimchi and things like that, because they're fermented and they have all these wonderful microbes in it. But the thing is, when you take them in and you swallow them and you digest them, they're no longer live, but their DNA and their byproducts as they're going in can be very, very helpful to feed the beneficial bacteria and increase. So a probiotic would be a bacteria that's live, stays live, like a spore, for instance. Probiotic would be a true probiotic. So we just kind of use that term loosely, but scientifically speaking, their kombucha wouldn't be considered a probiotic, but can still help certainly with gut brain function. And it's more like a pre and postbiotic, I would say, when you're using it for this type of reason, and can be very helpful as long as you don't have anxiety and you're someone who can tolerate the caffeine. Daniel, does activated charcoal help to treat lithium toxicity? Yeah, so activated charcoal is going to go in there and bind to whatever excess, whatever's going on with the toxic load, the toxic burden, and then you either excrete it out through your bowels, or some people will vomit and get it out that way. And it depends on the level of toxicity. So activated charcoal is just generally a binder, a very strong, potent binder. So it's not just going to bind to the excess lithium, it's going to bind to a lot of other minerals and things like that. So this is done usually in the hospital setting, especially if you're talking about toxicity, because you have to replace your electrolytes and your minerals, etc. So oftentimes someone's also getting some IV fluids while they're getting this activated charcoal. But yes, it can certainly help with lithium toxicity, but should be done under the direction of a doctor, provider, someone who understands how to use this, because you can deplete yourself of essential nutrients by doing this. And also, if you have issues with not being able to excrete waste, properly, you could actually end up with too many toxins in your system that are now kind of trapped and hanging out there too. So you could actually have a negative reaction. Yeah, as long as all your pipes, your valves are working well, yeah, that they will often do this in a hospital setting. Trinity C, hello. Can Trintellix also help with ADHD? So Trintellix is interesting in the fact that it's a multimodal antidepressant. It is working on serotonin receptor sites in different ways and different pathways that have a lot of downstream effects to increase dopamine and norepinephrine, which can be helpful for patients with ADHD. But I would say patients with ADHD and anxiety combination, or ADHD and depression, it's not something I would look at as like first line treatment for just ADHD as a solo diagnosis all by itself, just because I don't think it's going to be as robust of that effect. Yeah, it has those downstream effects to increase dopamine and norepinephrine and even glutamate to a certain extent. But it's not as a stimulant where, like something like Adderall, where you're really, giving your brain large doses of dopamine and norepinephrine and really creating that stimulant effect. There's no comparison there at all. But maybe if you're someone who doesn't tolerate stimulants, you have underlying anxiety or depression, and maybe you have some reactions like Jim was talking about where you get increased anxiety with them, maybe using something like Trintellix can be helpful. But also, you could also do alternative treatments. You can use mucuna purins, you can use adaptogens, things like lion's mane mushrooms, cordyceps. You could use lychee fruit. That's another type of adaptogen and type of nootropic type of medication. So nootropics are going to work more for helping to boost cognition and brain function. Others, your cofactors for dopamine, so B6, B9, which is folate, B12, also very important, as I mentioned, in that cycle of your neurotransmitters and creating neurotransmitters. SAMe can be helpful there, especially if you have the slow COMT. Can help modulate that. So yeah, there are a lot of things you can do besides Trintellix, and the reason I lean more towards those other treatments, Trinity, is just because if we're talking about a long-term treatment, which usually with ADHD it ends up being a long-term treatment, I tend to want to stay away from psychotropic medications like these antidepressants, etc., just because it's really hard to get off of them when you want to get off. And downstream long-term can end up causing emotional blunting. It may stop working, and then you go into that whole tolerance cycle of needing more. And then next thing you know, a couple of years down the road, you're now being polydrugged, meaning now we're adding in all these different medications, when in fact it was the medication that started it all. It was a domino effect. So yeah, I would advise to look at alternatives to medications to help resolve your ADHD and explore what could be causing it. Dr. Greenblatt has a good book on ADHD. It's called Finally Focused. Really good book that goes through all of the underlying mechanisms that can be contributing to ADHD and how you can help resolve it. So might be something to look into. Motisim, hello. Excuse me, let me get a drink of water. Sorry about that. What are your thoughts on ECT? So electroconvulsive therapy has its place. It is something that I have never been a part of using. I don't work in a clinic where we are utilizing ECT. I've never used it. I've had some patients when I worked in community mental health and more conventional mental health early on in my practice that did go and do ECT and got really good positive results. However, What I have to say about ECT is that though it can be helpful for these who are termed treatment resistant, we have to figure out why they're treatment resistant first before doing ECT, because though the few patients that I had that did it experienced positive benefit and they were actually able to eventually come off their medications, there are huge risks with ECT and not everybody has that type of response. Memory issues can significantly, be a problem. So the older you are, the more at risk you are for perhaps having issues with memory as a result of this type of treatment, which can then be very depressing, right? So we have to be careful with going to utilizing something this invasive without first figuring out why this person was treatment resistant. And what I like to do is prevent treatment resistant right from the get. What I mean by that is treatment resistant usually develops. I talk about this in my video on why antidepressants don't work. So a very common path to treatment resistant is, like I was mentioning to Trinity, I think, about the Trintellix, right? So say you start Trintellix or any antidepressant for depression or anxiety, and you're on it for a couple of years and now you want to come off, or you think you're ready to come off. You try to come off conventional way, you start getting withdrawal symptoms, which your provider tells you is actually your disease. So you're now told that you have to be on this medication for life. But what happens is it stops working, you need more and more and more. You get to a point where now you're really blunted emotionally, your depression is more severe, that they decide, hey, now we're going to add in an antipsychotic. You go through the same thing with that antipsychotic. You may end up going to 2, 3, or 4 different antipsychotics, and then maybe start adding in, well, let's add in bupropion with that SSRI. Now let's add in some maybe clonazepam or Xanax, because now you're a little anxious, right? And these are all really side effects that are happening with the medications, and we're just treating with more medications. And so eventually you get to a point where now you get that label, boom, you're treatment resistant. What do we do next? So you'll have the option of something like TMS, which is less invasive. So if you're considering ECT, maybe TMS would be the better approach, or ECT. So I would be looking at, instead of saying, oh, I'm treatment resistant, this is what my options are, figuring out, well, why are you treatment resistant? Why did you start treatment to begin with? And is there a way to kind of help scale all of this back and start deprescribing and start helping you deal with the emotions and the issues that you were put on the medications to begin with? I think that's a better approach. So that's why I don't really agree, I guess, so much with ECT. But like I said, I've seen a couple of patients that have gone through it and actually did very, very well. But it's few and far between, from what I understand, that have such wonderful results. So it's just something you have to be cautious with and explore what your root causes are to your condition first, and why maybe you're treatment resistant. I wish you the best, because when you're considering ECT, it's pretty serious. My walkies, hello. Hello, doc. Can you suggest me one medicine that works both for ADHD and OCD? Yeah. And I'm a psychiatric nurse practitioner, by the way. I know some people, will use the word doctor, etc., but I just want to clarify. I'm a psychiatric nurse practitioner. I do prescribe medications, which makes it confusing for people outside of the U.S. who don't necessarily understand that, because doctors are only prescribing in other countries. But here in the U.S., psychiatric nurse practitioners do have prescription privileges. Excuse me, anyway. So medication that could work for both ADHD and OCD. Really here, these are two different, how do I say that, like mechanisms in the brain, two different things that we're trying to treat. So there isn't one medicine that will work for both. And what I would start with is the OCD, because once you get the OCD down, so things like clomipramine, I just had a video on that one. Luvox, which is fluvoxamine, and then of course you have your other SSRIs, etc. But once you get that under control, then you can kind of see what's left over as far as the ADHD symptoms. Because like I mentioned earlier, if you start treating ADHD first when you have underlying anxiety, you can exacerbate that anxiety. I also want you to think about this. When I see someone who comes to me and they have ADHD and OCD, there is something I think about almost right away. And that is, could this be HPHPA? And you're probably thinking, what is HPHPA? Well, HPHPA is a Clostridia marker or byproduct of Clostridia bacteria in the gut that when it's in abundance can cause very significant symptoms that look like sometimes autism, sometimes OCD, especially with the irritability and those types of symptoms, and even like ADHD, restlessness, etc. And I see a lot of patients with these comorbid presentations like ADHD and OCD, or ADHD and autism, or schizophrenia and depression, or bipolar, and they have all these different combos, and we oftentimes will find this HPHPA marker. So how do you find it? Well, it's called an OATS test, an organic acids test. And the only one that I know of that actually tests this specific marker, because there's a lot of different OATS tests out there, but the one that I know that does test for HPHPA marker is the Great Plains or Mosaic Diagnostics, Mosaic Labs. They used to be Great Plains, but so that lab has that HPHPA marker in it, and you'll get a lot more information than that in the OATS test. That could also be contributing to this type of presentation. So I would be like thinking, what's actually underneath causing these symptoms? Could it be this Clostridia, as simple as this Clostridia marker, which, like I'm telling you, I see it a lot. So that's what kind of comes to my mind right off the bat. It could also be genetic issues. Someone with MET COMT could oftentimes have this type of presentation, or the MTHFR presentation as well. So there are a lot of issues that could be going on that could potentially be a root cause of your ADHD and OCD symptoms, and medication may not be helpful at all. You may actually need to look a little deeper than that, and also working with therapists that can help you manage some of these symptoms that you're having can also be very, very helpful. I've seen patients manage ADHD and OCD with just therapy alone, really. So I'd be looking at those things besides jumping into medications, because with this combo here, you go through conventional medicine pathways, you're going to be ending up right off the bat on multiple medications, and that could lead to a storm of events that could eventually lead to withdrawal issues in the end, or treatment resistance. Abel, hello. I'm trying to taper mirtazapine myself while waiting for the psychiatrist appointment. It's been challenging for the insomnia. Yes, tapering mirtazapine can be very challenging, especially if that's the reason you were on it and you were taking it for the insomnia. So you make up a good point here, because when you taper medications, it doesn't mean that all of the things go away. Tapering medication slowly is key to help avoid significant withdrawal symptoms. Even if you taper slowly, you may still experience and oftentimes do some withdrawal. But if you taper, slow and steady, you'll avoid something called protracted withdrawal, which is a very significant injury. Now, the issue that you are taking the medicine for, in this case, insomnia, doesn't just go away. So you have to figure out, well, why were you having the insomnia to begin with? So while you're waiting for the psychiatrist appointment, perhaps getting into therapy with an expert in insomnia treatment, like maybe CBTI, or really evaluating what started your symptoms of insomnia. Was it a life stressor? Was it a change? Could it have been, for some people, it could be like just the medical trauma. I've seen that happen a lot, where they get a scary diagnosis. Now they're up all night thinking about it until they get all the tests done. And then once the test's done and it alleviates, now, they're okay, but now they've created this pattern of insomnia because for weeks on end they weren't sleeping. They were in this anxious state. So there are many different reasons for why someone will develop insomnia. So figuring that out is key. Also, specific nutrients I like to look for in someone with insomnia in particular is going to be magnesium, zinc, and then going upstream your B vitamins, B6, B9, B12 in particular. All of those are necessary for serotonin production, and serotonin to convert to melatonin. Zinc is required for that transition. So I'd be looking at those. And then, of course, vitamin D. Vitamin D is very important. In that, I believe it's the second step there, and your omega-3s as well. So I'd be looking at those factors right off the bat, and then just basic other labs to make sure there's no anemia or anything like that going on, no stress on the body, no inflammation. The oats test too, I want to mention that because I mentioned it earlier with the other question, can also look at something called quinolinic acid. That's another important marker that can also be present oftentimes with insomnia. And quinolinic acid, what that is tryptophan. So you eat a piece of turkey, it has lots of tryptophan in it, and tryptophan can convert into 5-HT, converts into serotonin, crosses the blood-brain barrier, right? However, there's another pathway that it can go down, which is an inflammatory pathway that leads to quinolinic acid or kynuric acid. So when tryptophan is going down that pathway, oftentimes it's due to inflammation and high stress. So how do you know that's happening? Well, you really don't. You can guess that it's happening, but definitely an oats test will tell you if that's the pathway the tryptophan is going down. And you would want to get like antioxidants, anti-inflammatories, and things like that you take at night, because at night tends to be the worst symptoms when you have high quinolinic acid, and insomnia tends to be very common with that. So that's another thing I think about as well, as long as many other things. So it's just always really good to look for root causes, and while you're tapering the mirtazapine, remember that if you don't figure out why you had insomnia to begin with and start correcting that, tapering mirtazapine isn't going to resolve the insomnia. You know what I'm saying? So you've got to be proactive in that regards. And I always like to have patients start exploring that early on in the tapering process and start resolving a lot of those underlying issues early on, because if you don't develop those skills early on, as you go through the taper process, it can be very, very difficult, and you can be tempted to go back on the medicine or try other medications as solutions if you've never really dealt with the underlying cause of that insomnia. Daniel, hello. What's the numerological reason? Okay, Okay, gotcha. What's the neurological reason for schizophrenic auditory hallucinations? Well, we're talking about temporal lobe activation, too much dopamine. If we're talking textbook, I guess is what you're saying. Reasons for schizophrenia that can lead to auditory hallucinations. And this can be driven by many factors, like I mentioned before, inflammation being one of them. And with schizophrenia, if we're not talking about like a true biological presentation, like this person just has too much dopamine in this area of the brain, and that's the cause. If it might just be something like quinolinic acid can cause it, something like HPA can cause hallucinations. I've seen it. I've seen psychosis in patients with these markers. Then yeah, it could be a biological thing. It's genetic predispositions as well. So if there's a strong family history of schizophrenia. But I would also be looking at genes like the COMT. Are you not breaking down your dopamine properly? Could that be the reason? Are you not breaking down your B vitamins properly? Those types of genetics is what I'd be interested in with this type of presentation, to see if there's anything else we could help with that. Another thing that makes me believe more that it is more of an inflammatory driven mechanism, and not just a faulty like dopamine issue, is that the ketogenic diet, these past few years, doctors like Georgia Eve and Chris Palmer have been really paving the way for metabolic psychiatry and getting patients into ketosis and using the ketogenic diet to help patients with severe mental illness like schizophrenia, like bipolar 1, diagnoses that we thought only medications could treat. So when we see that resolving a lot of the problems, I really start thinking, wow, we're probably dealing with more significant inflammation in this type of disease process than we thought. And also just providing the brain with extra fatty acids that it needs. So, checking your omega-3s, your cholesterol. If your cholesterol is too low, you could also be in trouble. Your brain is primarily made up, like the actual substance of your brain is primarily made up of fatty tissue. It needs fat. So if your cholesterol is too low, that could actually be a problem. And I talk about that in my basic labs for mental health. But yeah, I would definitely say, if we're talking about the neurological reason, they're going to tell you increased dopamine, most likely in the temporal lobe region. But I dig a little deeper than that, and I start thinking of other mechanisms of how and why this person could have these types of symptomologies. Even infectious diseases could be a cause, just thinking of Lyme, chronic Lyme, and those types of diseases, mold toxicity, etc. Benzodiazepine fighter, Kerala Malu. Hello. Hi, I'm taking Klonopin 1 milligram. I attempted a taper, which was a total failure. 3-month taper led to protracted withdrawal and reinstated again. 1 milligram tapering now again. How long do you prefer taper duration? Well, you've got to go really slow. Months, how many months or years? You'd have to do the calculation. If you're down to one, you're at 1 milligram now, so you reinstated at 1. Okay, yeah, 3 months is way too fast. I can tell you that off the top. And also wondering if you're experiencing a dosing withdrawal, if you're not spreading your dose out. But let's just go off the 1 milligram. So if you already had a protracted withdrawal injury, you want to keep the percentage low. And so you want to be taking off, I would say 5%. I wouldn't even go up to 10% at this point, because you're a high risk for an injury or going into a protracted withdrawal injury again. And also something called BIND, benzo-induced neurological dysfunction, which is basically like a protracted injury that's related to benzodiazapines specifically, and I have a video on that. So yeah, I would start. I would get this compounded into liquid. So talk to your psychiatrist about that if you want to stay on clonazepam. Space the dosing apart. If you're just taking it once a day right now, you may benefit from twice a day. Most people do, especially at this milligram. Spreading that out, so maybe 0.5 BID or twice a day, and then start taking 5% off little by little, of the dose. And you could spread that out where you're doing it hyperbolically, like a micro taper over, where every day you're taking a little bit off, or you could do a cut and hold, meaning you take that 5% off and then you hold for about 4 weeks, and then take another 5% off. Sometimes when you've already had a protracted withdrawal, doing that 5% jump off the bat and then holding can be very difficult. So you may want to look at what that 5% would be, and then space that out over, say, 4 weeks. And then you would every day take maybe 1/100th of a dose. So you would need very small syringes to remove like 0.01, 0.02, etc. From your dosing each day to kind of get to that 5% jump at the end of the 4 weeks. And you may need a small formulation of the medication to make it easier as you continue to reduce. So all of those things are things to talk about, with your provider. If you want expert care in guiding you through it, if you don't have a doctor who is able to help you, then I would say go to the taper clinic. taperclinic.com, Dr. Joseph Wittering and his team, experts on this particular topic, and you will be supported with daily groups, taper sessions, etc. So yeah, but you definitely need to go slow. How long it's going to take? It's probably going to take. Depends if you can tolerate this very well. A year or two. Somewhere in between there. Modison, why you shouldn't stay on benzodiazepines? Well, let me preface this by saying that not everyone has issues with benzodiazepines. Okay, so this doesn't mean that everyone who's on a benzodiazepine needs to start tapering right now. Okay, because there are some people who can take a medication like Ativan, 0.5 milligrams. They take it for sleep. 20 years, they never increase their dose, they never have an issue, and it works for them. That's great. You don't have to taper, right? You don't have an issue. So why would someone want to come off benzodiazepine? Well, here's why. You start off with someone who has insomnia. Let's say that's a good example because it happens often, and they start taking a benzo. Let's start with that Ativan, 0.5 milligrams at night. You start to become tolerant, meaning now 0.5 doesn't work, you increase it to 1, 1.5, 2. Your doctor says, oh, wow, now we're at the max dose here to give you at once. And, and then you're kind of stuck, right? So you have one of two options. You can either start trying a different benzo and you can go through the same pattern. It's the same thing will happen. And eventually what tends to happen here, why people get off of this, is because it stops working. And now it's making you worse. So now that 2 milligram Ativan is not helping, but now it's actually causing what's called rebound insomnia, rebound anxiety. So it was helping for these symptoms or these issues to begin with, but now it's backfiring on you and it's causing those symptoms. The other issue is the side effects. So as you go increase the dose, now you start getting more of the side effects. So cognitive issues, so brain fog can be a problem. Depression can be a problem. The benzos are inhibitory, so you're inhibiting your neurotransmitters. You're causing this relaxation response. Over time, that can lead to depression, significant depression for many people. And then what can happen with many people, conventional medicine, boom, let's antidepressant, let's do this. And you're thinking, well, I just had anxiety. Why am I on all of these? Well, that's why, because the medicine is causing all of the problems. And so you can end up being polydrugged at the end or called treatment resistant and all of these other things when really the culprit was this benzodiazepine. So in my opinion, the best course of action to take is never to start it to begin with, to work on your root causes of anxiety, to get into therapy, to figure out your life stressors, whatever it was, like I mentioned early on with that question about anxiety and medications, etc., is really exploring what is going on underneath and getting to the root cause and treating that, because you'll be better off in the long run. When you hear people's stories, like I have an interview with Tomas Starchevsky that you can watch right now, another one coming out tomorrow, that these people, they were put on these medications to help them, and then they backfired on them, and they ended up in this very significantly injured state. Okay, Emma's interview, which will air tomorrow, hers was just a benzodiazepine, one pill. That was it. One medication over time did that to her, created a significant injury and sequelae of symptoms where she was, for many, many years undergoing some brutal issues that led her to go to the hospital, etc. But you'll find out her story tomorrow. Tomas, it started with Paxil, then sertraline, then all like he was going down that polydrug, state. And so yeah, all the stories, are different. Everyone's story is different, and it depends on, the underlying root cause, like I've said before. what could be causing the issues. And I believe that the more issues you have early on that's leading to that anxiety that don't get resolved over time, the greater your risk of having this protracted withdrawal or bind, benzo-induced neurological dysfunction, because a lot of the underlying issues and mechanisms of anxiety are inflammatory driven. And these types of symptoms are theorized to be related to significant brain or neuroinflammation. And so it's very important to recognize what's causing it and get to the root cause besides going to a medication. If you are going to resort to a medication like a benzodiazepine, just use it short term, 2 weeks at max, and get into the therapy, do the work, figure out the biological mechanisms that are leading to your symptoms and resolve those. And you won't have to be on a benzodiazepine and risk that, because it's like rolling the dice, really. We don't know why these people have these reactions. Like I said, I theorize it has to do with a lot of these underlying mechanisms that aren't looked at and then just kind of left at the wayside, and the person develops a lot of inflammation early on, and others do well. But do you want to roll the dice with something like your life and your brain, where you could be looking at an injury that could potentially last years and be very, very difficult to come off the medication? So I think when we say risk versus benefit, that risk is pretty heavy. And so you really have to think about that overall. And unfortunately, our culture really pushes this quick fix, pill for everything mentality, which is not correct. It's not. I don't subscribe to that culture. And so that's why you see a lot of people wanting to come off of benzodiazepines, and I will speak out about it when someone's asking a question about a benzodiazepine, because my intention is to reduce harm. Ultimately, I don't want to be part of the problem. I want to be part of the solution. So thank you for that question. I get on my soapbox with that. Sorry. JD, hello, ma'am. Best vortioxetine dose for cognition and treatment-resistant major depression. So, with vortioxetine, max is 20 milligrams. So if you're up there at 20 milligrams and you're not getting benefit and you're labeled treatment-resistant, then you might want to start thinking about all the things I just talked about and start exploring your root causes, etc. Or you can end up down the road of conventional medicine, where now you're adding on medications, and docs will start adding in antipsychotics at this point, maybe other types of antidepressants, maybe anxiolytics, etc., depending on your symptomology, and then you're heading down the road of getting TMS or ECT. So yeah, the dose is going to be 20 milligrams. That's the max dose there, but really I would get to that root cause and look at that book, Depression, Integrative Medicine for Depression by Dr. Greenblatt, will really help you uncover those root causes. Celia Budding, I'll just say Celia. What are your thoughts on using a very low dose of clonidine as a PRN for someone suffering the morning terror from benzodiazepine withdrawal tolerance? Thank you. Yeah, so I do oftentimes use these non-benzodiazepine medications like clonidine to help patients, and it can be very, very helpful during the withdrawal process. Now, of course, clonidine doesn't come without risk. There are side effects, etc. So make sure to review. I do have a video on that goes over that. If you have issues with low blood pressure, issues with blood pressure to begin with, there may be, or even high blood pressure, there could be rebound hypertension with long-term use of clonidine in the end, or if you try to get off of that you'll need to consider. But if you're just doing like a PRN 0.1 milligram in the mornings when you get that, because I understand exactly what you're talking about. A lot of that is the cortisol spike from the benzo withdrawal tolerance type of symptomology. But yeah, the clonidine can be helpful for some. It's not the miracle drug, because it may help some, may not help others. So you also have to recall too, when you're already in this state, withdrawal tolerance, several things you can try to do is make sure you're spacing your dosing out so that you're not in interdosing withdrawal. So that's something to consider. And then even with spacing out, if you're still dealing with some of this stuff, you might want to, of course, look at those underlying root causes I just discussed. I won't go in depth with all that again, but if you are then going to consider medication after you kind of checked all those boxes, right? Because that's like what I like to do before I jump to adding adjunct medications, because I don't like to use any medication, lightly, just start throwing medications at people to go through withdrawal, because it can add fuel to the fire. And so one of three things will happen when you start adding in other medications. Number one, it doesn't do anything. Number two, it might exacerbate your symptoms. Your body may not like clonidine. Or number three, it helps, right? So you have to think about that. If it's going to have a negative reaction, it's going to be almost immediate, if not a couple of days into it. So you can kind of just notice, okay, boom, and then stop it, and then kind of wait for things to settle down. But that can be very, especially if your terror symptoms that you're talking about in the morning are already severe, and you exacerbate that, that can sound alarming, to someone. So though clonidine can be helpful, it doesn't work for everyone. Other tools that can be helpful are like propranolol and hydroxyzine as well. It all depends on what I like when I'm thinking about this with the patient, and I'm looking at all of their symptoms, and I'm looking at their labs and their presentation. I start thinking, what is that mechanism behind it? What is causing? So when I think about using clonidine, I think someone whose cortisol's up, their stress response is up. And it sounds like when you say terror, that could be happening. Clonidine is really good at lowering that fear stress response. It's also a little sedating. So if you're kind of like wired and like that kind of presentation, I would definitely be thinking of that. If I think it's histamine related, if I think it's, boy, this person's having a lot of reactions to things and they're having anxiety related to that, and the anxiety is coming from that place, I'll lean more towards hydroxyzine. But I also know hydroxyzine is even more sedating than clonidine. So we gotta, kind of monitor that. You may just need a little bit too, maybe only 10 milligrams. Then propranolol. So propranolol is kind of like clonidine. If someone doesn't respond well to it, or maybe I think clonidine's too sedating for them, like maybe they need a little bit of that stress reduction, but they still have to work, et cetera, et cetera. Propranolol may be a better option because you're not going to get that sedative effect that you do with clonidine, but you will get it's almost like taking the edge off of that effect. But it does also reduce the stress and fear response, which is why it's used a lot in the early presentations of PTSD treatment and panic attacks, etc., and also used for social anxiety. So those are like kind of like my thought process as I'm going through thinking of those three. Those are the three I use more commonly in helping patients, just because of a lot of the other medications and adjuncts that providers will use, like Gabapentin, for instance, are basically just doing the same thing in the GABA receptors, maybe on a lower level. And so you're just kicking the can, because then eventually you're going to have to get off that gabapentin or pregabalin, because that's going to end up going down the same path, same issues as the benzodiazapine does. And so that's why I don't like to use those types of medications, or even antidepressants for that matter. Last resort for those, just because they can also lead to a lot of issues down the road with withdrawal and protracted withdrawal injury as well. So anyway, that's kind of like my process. So yeah, it can be helpful, but it may not be helpful, and you have to weigh that out, whether or not you want to kind of go through this litmus test, kind of testing and seeing, like, is this going to be the thing that helps me? So if you notice any type of increased symptoms, give it like a couple of days to see if it actually is a true pattern of the medicine causing it, and it is exacerbating symptoms, then then I would just let your provider know this isn't for you and maybe try something different. Cassie, hello. Hi. I had a random first panic attack followed by anxiety last year and since better without any medications. That's great to hear. Do you believe anxiety can go on its own? Yes, it can, especially if you have a lot of resilience. I talk a lot about resilience too. In some of like one early videos I did on burnout and building resilience, I really focused on that because this was something I experienced a few years ago now. But yeah, it can't go away on your own, especially when you have a lot of the things in place: healthy diet, healthy lifestyle, good exercise regimen, routines, those types of things. And if it was driven by a stressor, maybe unknown, um, and then it went away, your body's not, because maybe you didn't recognize what caused that. So meaning you're not um, being re-exacerbated by it. Like for instance, say if it was like a near accident, right? That could get someone like panic attack. Oh my gosh, I just almost got into an accident. And then every time they now get in the car and they start driving, those symptoms are exacerbated because that amygdala is like, boom, boom, fear, 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 and starts recalling in the car, you had a panic attack and this is what happened. And so it starts like basically like causing that experience all over again, to try to protect you and say, we don't want to drive today because we're going to get into an accident. So if it wasn't something clear like that, it is possible for it to just be like a one-off type issue as well, which can happen for people. So I'm glad that you didn't go down the route of getting scared where you ended up on medication and et cetera, et cetera. But as long as you work on building resilience as well, like work on healthy lifestyle, checking labs, making sure you're optimal in your nutrients, for example, and making sure your inflammation levels are down and you have a good routine in life, like you're exercising, etc. And I think really people, even if you don't have anxiety or like depression, or you don't have all these labels, which I don't really like labels anyway, therapy is just good. It's just good practice. It's good to get into therapy, to talk to a professional, even if it's just once a month. If you're not, if you're in a disease, quote unquote, labeled state of anxiety, depression, OCD, etc., then more frequent therapy is necessary. But if you're talking about, just kind of bouncing things off to someone, going once a month is a good cadence just for everyone to have, someone to kind of dump on, that it can be very objective, can be very, very helpful for releasing a lot of the tension that we tend to hold on to, and we may oftentimes feel like we can't talk to others about. So just going to therapy prophylactically, I think, is also good too. But yeah, thanks for that question. Shark, can Vraylar help with negative and cognitive symptoms in schizophrenia? Yes, it can, and oftentimes is used for that. It's also used as an adjunct for treatment-resistant depression, the term I don't like to use, because it has some good stimulating benefits, and it is partial serotonin and dopamine agonism. But the one thing with Vraylar, though, it can help with both negative and cognitive symptoms in schizophrenia. It can also induce akathisia. So you want to be very careful with that. And that is like that internal restlessness that you just have to it creates like this agitation. You feel like you just have to move. You have to move. Some people just pace, and do things. That's like an akathisia. And then when you see someone having that type of reaction, you never forget it. When I worked on inpatient psych and crisis in a crisis unit, I saw that a couple of times with patients who were started on antipsychotics, and that happened as a side effect, and it was awful to witness. But yeah, that is the risk. So to discuss that with your provider if it's something you want to try, but can certainly help with negative and cognitive symptoms in schizophrenia. JD, hello. Does acetyl L-carnitine really help with cognitive dysfunctions and major depressive disorder? It can help. Also can help with weight. I use it more for like weight regulation, so helping to reduce uh, weight as a side, like measure. SSRIs can induce weight gain and induce that sequelae of like this metabolic syndrome. So can antipsychotics. So acetyl L-carnitine can help with that too. But it can help with cognitive dysfunction. It's not my first choice with that in major depression. Um, I look more towards nutrient. I'm more nutrient focused. So I would look at assessing, your labs and looking at your B vitamins, your homocysteine, your vitamin D, your magnesium, specifically to see if any of those are perhaps root causes, and treating more with nutrients first before going into using like antioxidants and different other types of solutions to help with cognitive dysfunction. And herbs like rhodiola can be very helpful. Also, rhodiola is helpful for an ADHD type of treatment too. That's used as a kind of natural type of treatment. But even before, like using like herbs and adaptogens and nootropics and antioxidants and other medications, or excuse me, supplements like that, I would first kind of go through my nutrients as first cause, and omega-3s is another one. So get your omega-3 check, get your B9, B12 checked, get homocysteine looked at. Serum B6 is not very reliable, so that's why I don't check that. Um, and then, of course, like I said, magnesium and vitamin D could also be helpful to look at. Magnesium and magnesium RBC, I would look at for better magnesium picture, and then look at optimizing those levels to help with your cognitive dysfunction. But acetyl L-carnitine and acetylcysteine is also another one that can be helpful there. But certainly looking at those nutrients first would be what I would first want to dig into before jumping to acetyl L-carnitine. That's more like an adjunct. George, hello. Do you consider venlafaxine 75 milligrams and Buspar 15 to 20 milligrams? Okay, a good combo for chronic persistent depressive disorder and anxiety. I switched from escitalopram, which I was on for 10 years. Well, it can be. Venlafaxine can be, and adding in buspirone for anxiolytic benefits, you're getting now more of that partial serotonin agonism. And oftentimes this is also good for reducing blunting effects. So some providers will add in buspirone because if you get too much serotonin in like the hypothalamus and the emotional regulation centers in the brain, you can actually cause like this blunting effect, and which can look like depression. And they can say, oh, well, we're just your depression is getting worse. Let's add this, when really it's just the mechanism of this too much serotonin in that area. You're just flooding. You're kind of flooding the engine, so to speak. But yeah, if you switch to venlafaxine and you're adding in buspirone, that can help mitigate or lessen that effect, and can be a good combination for persistent depressive disorder and anxiety. But I would be just cautious, especially with venlafaxine. That one's one of the harder ones to come off of. So if you end up like needing more and more and more, that kind of pattern, and I would hesitate with that, just because if you end up max dosing venlafaxine and then need to try to taper off of that, that can be very brutal for many people. Actually, that's not a small percentage of people. I want to say probably 60 to 70% of people have issues coming off of venlafaxine. So you have to be very, very careful there. But if you're getting results, that's great. But I would also want to, George, just do your due diligence and look at maybe what could have potentially caused your depression and anxiety to begin with. Ibrahim, hello. Does Latuda cause less anhedonia than risperidone and Abilify? Less anhedonia. So anhedonia is like when you're not, just for people who don't know, not able to feel pleasure from things that maybe you once enjoyed. So Does Latuda cause less? Thinking of the mechanisms of Latuda versus risperidone, let's start with that one. Potentially, yes. It has a little bit more modulation abilities in different receptors than risperidone. And I'm thinking, when you're thinking of anhedonia as a symptom of, like, say, depression, or maybe just a flattening or blunting of emotions, which can happen, I think too much serotonin actually is going on in the brain. And so when we're looking at that, we want to think, does Latuda maybe modulate serotonin better than something like risperidone and Abilify? And I would say with risperidone, probably more so than Abilify. I think Abilify and Latuda are probably similar in its abilities to modulate serotonin. I'm not sure that it's going to cause less anhedonia. It might, especially if you're just comparing it to risperidone, if we're just looking at that aspect of it. But I would also then want to ask you, why do you think you have the anhedonia? Is it related to inflammation? Maybe it's related to too much serotonin, and your brain maybe doesn't need all of that. And maybe you just need to reduce a little bit. Sometimes reducing a medication dosage can actually give more benefit than adding more or changing and switching. So I would be thinking about that. And again, just kind of going back through those root causes that I've been talking about. I don't want to just keep rehashing them because I don't want to waste our time here. But you can see those. I talk about them a little more in length in that why antidepressants don't work. A lot of the root causes of anhedonia are going to be in that video because they're going to be root causes of depression. So look at that to kind of figure out what is exactly causing it, because it might not be medication driven necessarily. Okay, Emmanuel, hello. How to avoid developing tolerance in Vortioxetine? Is it really effective in the management of panic disorder? Is it nephrotoxic? So nephrotoxic is meaning toxic to the kidneys. And no, to my knowledge, it's not nephrotoxic. As far as managing panic disorder, no, it's not a first-line treatment for panic disorder. First-line treatment for depression can be helpful for depression with anxiety. As far as developing tolerance in Vortioxetine, all of the antidepressants like Vortioxetine have the potential to just keep causing tolerance. And it's really something that's unavoidable because it's not something you take as needed, like a benzo, for instance. Benzos are short acting, boom, work for 4 or 5 hours. At least if you have a short acting benzo, which most people, that's what they start with. And then you take it as needed. Maybe you're taking it once or twice a month. That your risk of developing protracted withdrawal, benzo-induced tolerance, et cetera, like zero, right? With a medication like Vortioxetine, to get benefit from it, taking it in that cadence, like once or twice a week or a month or something, doesn't do anything. It's the cumulative effect of that medication that produces these types of benefits to help anxiety, depression, etc. So when it comes to antidepressants and things of that nature, the tolerance, for the most part, is almost unavoidable. Though I have to say there are a subgroup of some people that can just be on low dose. I mean, I've seen 70-year-olds, patients who've been on like low dose Prozac, 10 milligrams for like most of their life, and it's helping them. So obviously they didn't develop tolerance. Why? I don't know. So it's, and it could be the underlying mechanisms I've talked about before. Maybe, they're not MTHFR. They don't have issues with COMT. Maybe their B vitamins are in line. Their diet is great. Like those other factors, right, that we talk about. So I would say, I guess, then kind of make sure that when you get your labs done, that you are optimizing your nutrients and optimizing your brain's ability to produce its own neurotransmitters. Because once you start optimizing your brain's ability to produce its own neurotransmitters, your dependence on medication is less and less, and you can actually that lower your need for vortioxetine or any other antidepressant for that matter. And a good book that goes over this in great detail is the Antidepressant Withdrawal book, the Guide to Antidepressant Withdrawal, using integrative, approaches, and that's by Dr. Greenblatt. That book is very good at going through the steps and kind of what to look for, root causes, and those types of things when we're talking about serotonin pathways and specifically. The other book, his book on depression, also goes through like kind of the root causes of depression in general. But that antidepressant withdrawal really dials in and has a lot of good that is very protocol focused, and labs that you would want to get, and then what those optimal levels are. So it's a little more detailed in that regards. So I'd be looking into that. But yeah, if you optimize your own neurotransmitters, perhaps you can avoid this tolerance in vortioxetine. But many people, even though they may be optimized in nutrients, I've seen them too also develop tolerance with other types of antidepressants. So just think about that as well. But I wouldn't be thinking this as a first-line treatment for panic disorder. No, it's more depression or depression with anxiety. Hello, Eric. How long can you stay on gabapentin before you get withdrawals? 2 weeks, 1 month? I'm on it for severe anxiety, but also for nerve pain, back pain. Yeah, 1 month would be the general, like most people. 1 month. If you're doing more than a month on something like gabapentin, but I have heard of people only take it for like 2 weeks and develop some type of issues with their GABA receptors. But that is not common. So I would say anything more than a month, for sure, you would be at risk for withdrawals, and then definitely anything more than 3 months, you would definitely be looking at needing to taper this medication very, very cautiously. If it's something you want to taper, if you're having issues. So just like I talked about when the one comment came through about, well, why do you want to stop benzodiazapines? Like, why get off them? Same thing with gabapentin. If you're maxing your dose, you're going up and up and up on the dose, you're now developing tolerance. It's now no longer helping. Maybe you're having issues with balance, poor concentration, poor memory, those types of things. Then that's probably where you're thinking, oh, this gabapentin is probably doing more harm than good, and maybe want to come off. It could also lead to depression, just like those benzodiazepines do with long-term use as well. So if all of a sudden you're now developing significant depression and those types of things, yeah, I would be looking at gabapentin as the culprit in that type of presentation. You also have to weigh risk versus benefit, like if it's helping your nerve pain or back pain, and talk about these risks and weighing them versus the benefit with your healthcare provider as well. And then, just as I mentioned before, looking at those underlying root causes. When it comes to nerve pain, back pain, those types of things, make sure your anti-inflammatory diet, you're reducing your inflammation, your inflammatory load, your inflammatory burden, because that would definitely be something that would be beneficial for someone who's going through, cognitive issues or dealing with nerve pain or back pain. Because I'm thinking like inflammatory response on the nervous system there. So thinking about that, if it's driven by something like diabetes, because oftentimes that could be a secondary issue with those who have diabetes, you really need to be cleaning your diet, anti-inflammatory, eliminating sugars from your diet, like added sugars and those types of things from your diet for sure, and you can get significant results. JD, can I interact with you through video call? I'm very depressed. My what do you call that, link to set up a coaching visit consultation is on my website at levelheadedmind.com. My availability is more limited right now as I'm working 2 jobs right now. So yeah, so you can look on there and see on the calendar if my availability is matching, what your schedule is like, and see if I could help you, because I certainly can help with guidance. I can't prescribe to you in that capacity. It's just basically a consultation where I provide you with some education, some ideas, some recommendations that you then will take back to your provider that you're working with, and go from there. And then if we want to kind of touch base later on as a follow-up, that's something we can do as well. So yes, you could, but my availability unfortunately is becoming more limited. And I'm not sure how long I'll be able to continue to do those types of consultations, to be honest. So yeah, if you want to get in on a video call, you can check the calendar and see the availability. But I know it's gotten less just because I'm working 2 different jobs right now. Massima, hello. Can lamotrigine push the effect of Trintellix if it's not working good enough? Lamotrigine and Trintellix. Now using lamotrigine can impact. Okay, so when you adjunct something like lamotrigine, now we're talking about sodium ion channels, like opening the gates, so to speak, of the neurotransmitters in general. So adding lamotrigine can be one of the tools that psychiatrists or conventional practitioners use to help with boosting antidepressant benefits or effects on mood. And so, yeah, technically, it can actually boost the effects of potentially of Trintellix just by opening those gates and letting those neurotransmitters flow more readily, and also balancing out with mood, especially if there's a presentation of irritability or emotional dysregulation too. Lamotrigine can be helpful for that type of presentation. Hey, hello. Any recommendations on how to measure the social rhythm metric? I'm not sure what you mean by this. There is something called social rhythm therapy. It's not something that I am an expert in at all. I've heard about it, and also know that it can be effective for some patients, especially when it comes to like bipolar, and those types of things, and utilizing kind of figuring out what patterns are creating like the symptomology, and then putting interventions into place to help support that person through that process. But beyond that, I'm really not sure how to measure the social rhythm metric. I'm not sure what that metric, what that means. Maybe if someone is an expert in social rhythm therapy, they would probably understand this. But unfortunately, this isn't my specialty, so I can't really make any recommendations. I'm sorry. Hello, can your brain recover from benzos, and how long does it take normal? I was thinking 0.5. Oh, you were taking 0.5 lorazepam. Can you recover? Yeah. Oh, okay. So you're saying you were taking 0.5 and maybe you tapered off or you got off of it, and maybe you're dealing with some symptom. Maybe it's a protracted injury or something like that. Yeah. So your brain does recover from benzo induced neurological dysfunction or protracted withdrawal from benzodiazepines. How long will that take to normalize or stabilize? Varies. And I'm sorry, it really does vary from person to person, so I can't give you a number. What I can say is, on average, 1 to 2 years post medication use, average. But then you have people that it takes them a lot longer, 5 years, 8 years, so, and I don't want to say that to discourage you. Oftentimes it's related to the severity of symptoms you're currently experiencing in this protracted state. Usually the more severe it is, the longer it tends to take. You have to be careful though in a protracted injury. I was going to say you can start looking at root causes. It's kind of, at this point, you're very, very sensitive to a lot of things, including natural like supplements, like B vitamins, for instance. So if you start kind of going down that path and uncovering root causes at this point, trying to mitigate that or lessen that burden and fix it can be very challenging. So working with a provider who understands this is important. And if you find things that are deficient, because oftentimes I see vitamin D very deficient in protracted injury, omega 3s being very low because inflammation is really overtaking the body. So you would want to reinstate these things very, very slowly. So I would get like a drop, liquid vitamin D and do like drops, like kind of slowly titrate it till you can tolerate it, kind of a thing. Omega 3s, get it in liquid, better absorbed anyway, but just do like little drops of the liquid of omega 3s if you find that's what you need. So you do want to look at, and especially I'd be looking at the B vitamins and then omega 3s, vitamin D, and then looking at inflammatory markers, high sensitivity C-reactive protein, and Ceterate ESR. Those are two common ones. Tumor necrosis factor alpha and interleukin 6 are others, but they are often not covered by insurance, unfortunately, and they can be costly for some people. You could do a morning cortisol, or better yet, diurnal, which is saliva over time cortisol, to see your curve, to kind of see where it's spiking, to kind of to use some anti-inflammatories like curcumin, turmeric, etc. So working with an integrative provider could be helpful, but always know that anything, and when you're in this state of protracted withdrawal, you're going to be very, very sensitive. And if you listen to Tomas's interview, he was in protracted withdrawal for some time, but he was on multiple medications, not just benzos. But when he started kind of getting out of that negative mindset of healing is never going to happen and that he could heal, he kind of had to put himself in positions where he says he had to fake it till he made it, right? He had to put himself in social situations and pretend he was engaging and pretend he was actually feeling emotions. Because oftentimes you don't feel a lot of emotions. You have this heavy depression that kind of comes over you in this type of withdrawal state. But he kind of forces himself and integrated himself into situations where he was around others. And eventually he started having, these symptoms actually started to become real. Like he started actually, when he smiled, he actually felt the emotions of happiness. When, he was actually reacting, he was actually being sincere. So that was kind of like exposure type therapy and like kind of allowing the brain to recall like what it's like to feel these types of emotions. And then also for him, he really utilized like a ketogenic type diet and exercise. So kind of slowly getting into exercise, because oftentimes too, when you're in this state, you're maybe feeling very weak, or going outside seems very like daunting. So it was first like maybe just walking around in the house, getting some steps in, doing walking, then walking maybe out to your mailbox, then maybe walking around the block. So again, kind of slowly integrating exercise, and then with diet, slowly like eliminating processed foods, start there. Eliminating added sugars, start there. You kind of graduate into this type of diet that could potentially help you. So it is a step-by-step process, and that can help the healing journey as well when you eliminate these things and kind of help your brain get back online, so to speak. But there are also people who don't do any of that and eventually heal. So the common denominator amongst protracted withdrawal people and healing is time. Really, that's it, time for healing. And then all of these other things can potentially help in that healing journey, but you just have to be careful when you're integrating these different types of modalities, knowing that your nervous system is more sensitive, and so you have to do things much, much more slowly, at a slower pace than someone who doesn't have this type of nervous system injury, as someone who does, who comes off of benzodiazapine. So it's really not related to the dose and coming off, like, all of those things. And like, then we have this time, like, oh, you were on 0.5 of lorazepam, so that means your recovery is going to be 6 months. No, there's no formula like that. It just varies. And commonly we say 1 to 2 years, but it could be less or it could be more. Astanapan, hello. Can you tell me an alternative treatment for those who develop jitteriness or anxiety syndrome when taking SSRIs? Lower the dose. This signals to me this SSRI, this anxiety could actually be too much serotonin. When you look at the sequelae of serotonin syndrome, a prodromal, meaning not full-blown serotonin syndrome, but like right before you end up with serotonin syndrome, like too much serotonin, is developing jitteriness and anxiety. So look at reducing those SSRIs. Look at alternative treatments. Yes, first going through those basic labs for mental health, making sure that your deficiencies, you don't have any of those deficiencies. If you find that you do, start replacing them, okay, slowly, so that your brain can start producing its own neurotransmitters effectively. And then look at ways to reduce inflammation, because inflammation tends to be a driver of a lot of mental health issues. And things like anti-inflammatory diet would be a good way to kind of start in. And then if you want to be a little more aggressive, go to something like ketogenic. But certainly, like, just working with someone who can help with integrating these types of practices as alternative treatments to SSRIs. Things like magnesium glycinate can be very, very helpful and often very well tolerated for people who are experiencing like jitteriness, anxiety. L-theanine can be helpful. L-theanine can also lower inflammation that's driven by something called quinolinic acid, which I talked about earlier on. So if you find that's a factor, that's something that you do with an oats test. So it's not like a simple blood test, but that could actually be a driver of the anxiety. So things like L-theanine can be helpful, and things that reduce inflammation like curcumin, turmeric, etc. Can be also very, very helpful with this type of presentation. But if you're currently still taking the SSRI and you're experiencing this, the first step I would be doing is lowering that dose. And depending on how long you've been on it, you may have to do it very, very, very slowly and cautiously, because I believe this is oftentimes an issue of, kind of dipping over into potential serotonin syndrome, and your body doesn't need more serotonin. So consider that and talk about that with your provider, and consider the alternatives thereafter. After you start tapering, you start feeling better, then you can start integrating some other nutrients, etc., to help your nervous system get back online. Digit Nomad, hello. Does Abilify will call me? Okay. Does Abilify cause blurred vision? So I'm guessing you're on 2 milligrams. Does it? Okay. So will it be gone when tapering dose, and when body gets used to it? If so, how long? Okay, so I think what you're saying is, does Abilify cause blurred vision at 2 milligram dose? Does it go away when you taper the dose after your body gets used to it? And if so, how long does the tapering last? I think that's what you're saying. So yeah, antipsychotics have a lot of potential adverse effects and side effects. Blurred vision can be one of them. Not commonly, but can be an issue. If you're on 2 milligrams right now, say you've only been on it for, let's say you've been on it for less than 3 months, your ability to taper off of it is going to be higher, especially if you've never had issues tapering off medications before injury. Now, if you have tapered medications before and had significant injuries, then your risk is going to be high and you have to go very slow. If it's only been a month to 3 months, I would say, you could start doing like a quarter, to see if you could cut that in quarters. If that doesn't work for you, if you have issues with that, like reducing by like a 25%, um, then you may have to reduce a lot slower, 5 to 10%. And with that, you're going to need compounding pharmacy. You're going to need liquid formulation, or compounding pharmacy. You can make the types of dosages you will need, because the smallest dose with Abilify, I believe, is 1 milligram tablet. It might be the 2 milligrams. Um, Gosh, I don't prescribe Abilify that much anymore, so I can't remember if it's 1 or 2 is the lowest dose. I think 2 might be the lowest dose it comes in. But just ask your provider about that. But I would start off with cutting it, by 25%, like every couple of weeks. See if you can do it that way. And you should, yes, notice the vision, blurred vision going away if it was related to the Abilify. If it doesn't go away after tapering, then of course you need to dig into figuring out why. And it might not be a bad idea just to get an ophthalmologist visit, to see if there could be something else causing the blurred vision as well, just to be certain before even considering the tapering. But if it's causing other issues on top of just the blurred vision, then tapering will probably be the safest to do, because it could be causing other neurological issues as well. JD, hello. Can I go up to 30 milligrams of Vortioxetine? It really helped me for cognition and MDD, but I forgot that exact dose. Well, 20 milligrams is technically the max dose for Vortioxetine. However, there are some people who can tolerate higher dosages, especially if you're a faster metabolizer of, I believe it's the CYP2C9, I want to say, with Vortioxetine. I'm pretty sure that's what it is. But that's the primary metabolic, like the pathway that it goes through the liver. So if that is the case, then yeah, that's where people will respond to those higher dosages of Vortioxetine. And in that case, depending on how fast you're metabolizing it, you could probably safely go up to 40. But then after that, you would definitely be more at risk for side effects of the medication. But in general, in the absence of any type of metabolism issues, 20 milligrams is the max dose of Vortioxetine. Delia, hello. I was on 75 milligrams of Quetiapine for 1 year. I've been trying to quit and have since tapered to 12.5 milligrams. So that's great. That's wonderful. However, insomnia started. Tried to replace it with antihistamines, but failed. Please advise. Okay. Took Quetiapine for mood disorder. Okay, got it. Yeah, so we've got to work on the insomnia is a very common issue, even though you were taking it for a mood disorder, because of its effects, the Seroquel Quetiapine's effects on sleep, on histamine in particular. So taking an antihistamine wouldn't be the best choice with working on this. So what I would be looking at is magnesium glycinate can be very, very helpful. L-theanine can also be very, very helpful here to take at night. You can take the combination together. You could start with one. Magnesium glycinate to get real benefits for sleep. Start at 200, but oftentimes you need as much as 400 milligrams or more with magnesium glycinate to help with calming the mind down, helping it to deal with this issue with sleep. Clonidine may also be helpful here. I talked about clonidine with another patient who was going through some benzo withdrawal, like in the morning, and wanting to use it. In Seroquel, a Quetiapine withdrawal can be helpful because it's a completely different mechanism of action, and so it's not doing the histamine, because with Quetiapine you do have histamine blockade, which is why it's very, very sedating. Okay, and that's why when you try to use that antihistamine to try to calm the insomnia down, it doesn't work, because you're tapering off and you're trying to get these neurotransmitters back online, so to speak. So it's going to have the same kind of rebound effect, or maybe make insomnia worse. So utilizing something more like the beta blockers, or in clonidine's case, alpha 1 and 2 antagonist, or could be very helpful. So that's as far as using medication, maybe an area you want to explore with your provider, and then think about with withdrawal, you're creating a lot of neuroinflammation and stress on the body. So using things like magnesium and L-theanine can be very helpful. But then also look at your labs at this point and see if there's anything else you need to optimize. Maybe your omega-3s, so do an omega-3 check, aren't substantial, and you need to really increase your omega-3s to help boost anti-inflammatory benefits in the brain. Maybe your B vitamins aren't completely online. Your zinc isn't up to par. So zinc RBC, zinc, plasma zinc, and then also look at copper too. If that's too high, that could cause some of this insomnia too. But I would be thinking of those things, and making sure I'm optimizing those nutrients in general. Going through the basic labs for mental health, making sure you're checking all of those. And then, you could use those, because magnesium, L-theanine tend to be well tolerated amongst many. Very little people have reactions to those types of supplements, but it doesn't mean that 100% of people. It's just, I'd say 90% of people. I'd say 9 out of 10 of my patients who are going through withdrawal, if they try magnesium or L-theanine, do fine with those. And it also depends on your level of kind of like withdrawal symptoms as well when testing these things out. But those two tend to be very helpful. And then the rest, you would have to look at to see if you need. Omega-3s can be helpful, vitamin D can be helpful, zinc can be helpful, but if you need it. So we have to see what your biology is telling us, right? Lithium orotate. I haven't spoken about lithium orotate yet today, but that can be also like kind of this tool you use. It's nutritional lithium, so it's not like taking lithium carbonate in hundreds of milligrams. Like just using like 1 or 2 milligrams of lithium orotate can also help with that brain inflammation. So if this is being driven by brain inflammation, lithium orotate can be very, very helpful with lowering that. So those are all some kind of ideas and things that you can try. That can be helpful, but please, go over all of these options with your doctor. Don't just do them on your own, to make sure that there aren't any interactions with other things you're taking, etc., and that it would be suitable for you. And then also look at those labs, and making sure that you are optimizing your nutrients at this point before going down any more. You want to get this insomnia kind of in check. And then, of course, not looking at supplements and nutrients and other things like lifestyle, making sure your sleep hygiene is good. I have a video where I do talk about sleep hygiene practices. It talks about blue light blocking glasses, like what are they all about or whatever. But in that video, I talk about a lot of things that you can do to help with sleep. Vagus nerve exercises can be very helpful. If you look up yoga lifestyle with Melissa, she has really a lot of videos on vagus nerve. She even has one on vagus nerve exercises for insomnia. So now we're working in the lifestyle area where you can actually help get your nervous system calmed down to induce a relaxation response. And those are different pressure points, different points in the body that can stimulate the vagus nerve. So looking at those videos and going along with those could also be very helpful. And just being mindful of your sleep hygiene, I think, is also good to think about too. So those are all kind of like in general when you're looking at trying to deal with insomnia while withdrawing, is because this is something that will continue, until you get this kind of in check as you taper off of quetiapine, just because of its blockade on that histamine. Really, now you're kind of having this rebound effect because you were on it for over a year. So yeah, but I'm glad to hear, and I'm proud of you for being able to get to the 12.5 milligrams. That's actually a good sign that you've been able to do that. So that's good. We just have to now kind of get the insomnia in check so you can continue with the taper process and make it tolerable. Hamza Ali, hello. How to overcome low libido on clomipramine? Oh, geez, yeah, this is hard. Unfortunately, clomipramine is one of those that has a high risk of sexual dysfunction and low libido. It's a tricyclic. Um, okay, so things you can do to overcome it. I'm guessing you're a male, Hamza. I don't know. Okay, so because it depends on male versus female, with herbs and stuff that you would use. So like tomcat, for instance, can be helpful if you're a male. Ginkgo biloba can be helpful for both male and female. Ginseng, both male and female. So I guess we'll stick to more of those. Um, so those could be helpful. If we're talking about medications, something that can be helpful if it's low libido would be adding in something like buspirone. Because of that partial agonism, it'll turn that excess serotonin down in the hypothalamus, which is where this is coming from. The emotional blunting, the sexual kind of arousal centers in that area. Oh, too much serotonin can lead to this. So if you want to add in medication and go down that route, buspirone, though I don't advise it because now we're kind of creating this dependency on medications, which can end up causing trouble in the long run, which I've talked in length about. But that is one way to help it in conventional medicine, but just know the risk of potentially dealing with treatment resistance down the road and perhaps needing to taper the medications, and which can lead to significant withdrawal injuries can be a factor. So I would look more at increasing nutrients. B vitamins sometimes can be very helpful in the low libido presentation. Yohimbe can be very helpful as a herb to help with this, and I think with Yohimbe, male and females can benefit from that. But just looking at those types of different herbs can be helpful. Ginseng, ginkgo, because all of those can be very helpful in boosting libido and trying to help overcome this effect. You may also want to look at reducing the dose of clomipramine, as you know, because of that serotonin effect that it's having in that part of the brain. Reducing the dose could also be helpful, but then it might not be helping your symptoms that you're using to treat the clomipramine, like maybe OCD or something like that. But then again, maybe you never addressed the root causes of the OCD or whatever issues that led to your use of clomipramine. So investigating that would also be something that I would look into, so you can help avoid the use of these medications to begin with. Because some people go on to develop persistent sexual dysfunction even after they stop antidepressants, SSRIs, and even tricyclics. So you just have to be careful with that, because it's something that could potentially develop down the road too. Okay, so we've got 15 minutes, so just make sure we're getting our questions in, and we're going down the line, but just kind of giving you that mark here of 15 minutes. Calvin, hello. Dear Dr. Rosa, I'm a psychiatric nurse practitioner. I never want to be misrepresented, okay? Is there any link between depression and slow gut motility? Oh, absolutely. I had constipation when I was having major depression. Absolutely. There's a link between depression and slow gut motility. There's also a link between slow gut motility and depression. So I have a video on the gut-brain connection and how, you know, our gut-brain axis actually can be one of the root causes of producing depression and even anxiety. So, and it all has to do with the microbiome. So if you're dealing with constipation, oftentimes that tells me there's dysbiosis, which means you have an overabundance of non-beneficial bacteria that cause a slowing down of the gastrointestinal system, okay, and can lead to this constipation. And there are several strains that can cause this, and I want to say the Firmicutes strain, an abundance of that, but I'm not. Don't quote me on that because that's not something I'm still studying this. Actually, I'm still a student in the whole gut brain connection and doing a course with Karan Krishnan actually that just recently finished up, and I have to go back and review my notes in that. But this is definitely an area of study that interests me, that piques my interest, because it was one of the factors for my issues when I ended up going through significant PTSD symptoms back in 2020. But anyway, yes, this answer to your question, there is a link. What you want to start doing is enhancing diversity of fruits, vegetables, nuts, and seeds if you can tolerate them into your diet. Think about consuming 30 different plant, varieties of plants within 1 week. Be creative with that. That'll help increase your prebiotic fibers. There are things like Mega Pre that can be helpful. Make sure you're drinking plenty of water. And then with specifically this presentation of constipation, slow gut motility, and depression, Mega Guard can actually be very helpful for facilitating movement and getting those different microbes back online. That can help with facilitating peristalsis, which is the movement in the bowels. So yes, there are lots of things you can do. There is certainly a link between depression and slow gut motility, and oftentimes it's the slow gut motility that can actually lead to the depression symptoms and this constipation. Absolutely. So yeah, just fixing up your diet, drinking more water, getting more prebiotic fibers, maybe using something like MegaGuard can be very helpful in helping this along. And then my favorite probiotic, as I mentioned in a couple of videos now, is a Megaspore probiotic. That is a probiotic I use and I found great benefit with, and a lot of my clients use and find great benefit with as well. Just because of it has tons of research. If you just look Megaspore probiotic, you go to their website, there's tons of research studies on that specific formulated brand that they put the money into to show that it actually works in many different ways on reducing inflammation, reducing lipopolysaccharide, which is a neurotoxin and a huge inflammatory driver of autoimmune conditions, etc. But anyway, that is my favorite probiotic that I use, and it's good to use as maintenance even after things resolve, just to prevent things from going back to a dysbiotic state. But anyway, yeah, thanks for the comment. Healing and yielding, I love that. Why don't psychiatrists check for low hormone levels before they prescribe antidepressants? That's a good question. I talk about hormones in my video, Basic Labs for Mental Health, and it is good to check, your hormones, see where they're at. But the reason why psychiatrists don't do that is because it's not something that's taught in their psychiatry track, like taking down that track and studying hormones to that effect. And really, even when I check them, and if I find some significant issues with hormones, I will refer to a hormone specialist, an integrative hormone specialist, if I can find one in their area, because they'll better understand about using bioidentical hormones, et cetera, to help the person, because it's out of my expertise. But what I guess psychiatrists and even psychiatric nurse practitioners like myself don't really understand is that you have to rule out issues like this and other medical conditions, because that's what it says in the DSM. We have, before slapping a diagnosis on someone, we have to make sure we're ruling out medical conditions. Unfortunately, the psychiatrists, the psychiatric nurse practitioners have become very complacent in just saying, oh, well, they were referred by their PCP, so we assume medical conditions were ruled out. Or they're coming with basic labs, CBC, CMP, and maybe a TSH, and they're saying that's ruling out medical conditions? Ridiculous. Sorry, I get on my high horse here, but this is just something that that I feel needs to be like driven home. If you're a psychiatrist, if you're a psychiatric nurse practitioner watching this right now, do not be afraid to check for root causes of mental health symptoms. It is our job to check for root causes of mental health symptoms. Just because you find a problem, like an autoimmune disease, like a hormonal issue, like something that is out of your scope, doesn't mean it is in your ballpark to treat it. It means then you refer them to the proper care and you save this person from the sequelae of needing medications that would never help them to begin with. You prevent harm by throwing in psychotropic medications for conditions that are medical, like hormone imbalances, right? Like thyroid dysfunction, like autoimmune conditions. I can go on because these are things that I find with patients, and oftentimes the solution is not psychotropic medication. Oftentimes the solution is something else. It's treating the underlying root cause. So I can't speak for all of the psychiatrists out there, but I know most of them, the reason why they don't check for blood levels, hormone levels, or labs at all is because they're afraid. They don't know what to do with the tests when they get it back. They're like, oh, it's out of whack. What do I do now? And they think they have to treat it. But that's not the case. They just have to be able to refer to someone who can. So anyway, sorry about that. I'm very passionate about it. JD, hello. How can we avoid tachyphylaxis of antidepressants? Does Pendolol? Tachyphylaxis, I'm not, that term is not familiar to me. I'm thinking what you're thinking of is maybe a tardive presentation, maybe a tremor type presentation, or tachycardic presentation, which can all happen with antidepressants. In that case, beta blockers, I'm not sure about Pendolol as well, but it sounds like a beta blocker to me. I would, like propranolol is a common one that's used when someone's having say a side effect like palpitations or something like that with antidepressants, or maybe they're getting a fine tremor, etc. We often see a lot of this type of sequelae too with the antipsychotics, where they'll use a beta blocker like propranolol or something to help treat that. So yes, beta blockers can be helpful, but as I've been saying this whole time, we want to make sure we're dealing with root causes, because now we're adding more medication to now treat side effects of another medication. This is not the way to go, because now you're setting yourself up for polypharmacy and that slapping that label of treatment resistance. It's tolerance. Okay, so you're saying the tachyphylaxis is tolerance? Is that what you're saying? Okay, I never heard of that term to mean tolerance. But okay, so if you're going to add a beta blocker to help with tolerance of antidepressants, that is interesting. If you're using the antidepressants maybe for anxiolytic benefit, I could see the use of beta blockers in that case. Antidepressant benefits, though, probably not, though I haven't really seen any studies related to this. So that's something I would have to look into a little bit more. But if we're talking about tolerance, then again, I'm saying what's really causing your depression and why are these medications not working and leading to this tolerance? Like you're just going down that same pattern that gives you the label of treatment resistance. So do your due diligence and look for those root causes. The video, Why Antidepressants Don't Work, is a very helpful resource for that. Okay, we have time for a couple more questions. Blessed One, oh, I like that name. Why supplements are used for motivation and intrusive thoughts? Oh, which supplements, sorry, I said that wrong. Which supplements are used for motivation and intrusive thoughts? So for motivation, a lot of supplements that can be used would be nootropics. So when I say nootropics, like different types of, like rhodiola would be considered a nootropic. Lion's mane and mushrooms would be considered a nootropic. Cordyceps, lychee fruit can be considered a nootropic. Green tea extract, etc. And those things can help with motivation, with energy, etc. But they might exacerbate intrusive thoughts. So if we're talking about both here, gosh, with intrusive thoughts, I often think about that HPHPA too. So making sure we're ruling out potential root causes. But if I'm just looking at that, like trying to tamper that down with supplements, inositol comes to mind. Inositol is very effective for intrusive thoughts, very effective for OCD, and there are research studies using inositol for OCD and this type of presentation of intrusive thoughts. Inositol, though, you have to, because it can cause a lot of nausea, and to get to a therapeutic dose of, say, 9,000 milligrams, which you would divide, like, say, taking 3,000 milligrams 3 times a day, you have to titrate it. So getting a powder of the inositol and then slowly titrating that dose until you can tolerate that amount. You could go from 9,000 to 12,000 for some people. It is a good dosage range, but just slowly titrate and see what works for you, because I've seen patients respond to just even 6,000 milligrams of it when it's for OCD or intrusive thoughts. So maybe you just need 2,000 3 times a day. But you do need it like 3 times a day just because of the short acting of it, and to continue that, if we're dealing with that type of presentation. So the inositol may not of itself help with motivation, but if your lack of motivation is driven by the fact that you have these intrusive thoughts and it's hard for you to overcome them to start doing any kind of work, then I would say start with the inositol. Because if you start with the nootropics to help with motivation, you could actually make those intrusive thoughts worse. So start with the inositol, get up to, slowly. And when I say slowly, like, maybe start with 1,000 milligrams a day, then kind of increase, by 500 milligrams like every week, to kind of get spaced out, to go up on the dose, and then find what works for you. And I would say, if you're at 9,000 milligrams and it's not helping at all, then it's probably not going to be helpful for you. But definitely, do that slow titration so you don't end up with severe nausea or gastric distress. And then once you get that managed, just kind of check in with your motivation and see how that, if it's helped, perfect. If not, then maybe consider adding in some of those nootropics I talked about earlier. Okay, so I think we have a lot of questions left over that I did not get to answer. Let me see here. We have... yeah, what we can do is answer these questions in the newsletter. I'm not sure how many are left. I'm trying to figure that out. I think Raul can tell me. Oh, there's 13 left. Yeah, I'm not going to be able to answer all those. So, so what I'll do, sign up for my newsletter, levelheadedmind.com. Towards the bottom, you can sign up, or there might be a pop-up that comes up where you can sign up for the newsletter. And I will get to... I'll look at all of them, and I'll answer like 4 or 5 in the newsletter. Sometimes a lot of the questions are similar, so I kind of combine them in the newsletter and answer them. And then also with the newsletter, you'll get some articles that could be helpful in answering some of the other questions, some videos that can be helpful, and then the link to the next live, which we'll do in December, 3rd week of December, I believe is the 21st of December, if Raul is available that day. We will plan on doing it. He says he is available. So the 21st of December will be our next live. So thank you all for being here, and for wanting to, be advocates for your mental health care journey. That's what I want this channel to be, a resource of education for you all, so that you guys can stand up for yourself, when it comes to treating your mental health symptoms, and also understand the mechanisms of these medications, but also understanding the risks of them as well with these different treatments. And also consider holistic treatments, integrative approaches. I have a whole playlist of them that could potentially benefit you to a point where you may not need medications at all. And consider that skills before pills approach. If you want, you can become a channel member, $4.99 a month here on YouTube. What that means is you get an extra live all to yourself. That is just for channel members. We have 9 channel members right now. So you can go in there and you can type in questions. I can answer them in lives. You can come and join the lives and get more one-on-one type of interaction with me. And I also like to, if there aren't any questions, do videos that pertain to different mental health topics and kind of help build resilience in you guys, so that you guys can bolster your ability to fight stressors in the real world, right? Because it's really the event of multiple life stressors that oftentimes leads to these mental health symptoms that we pathologize in conventional medicine. But anyhow, if that interests you, consider becoming a member. You'll get a lot of resources there. There are tons of videos already on there right now that would be very helpful for you. So thank you all again for watching and for being here. And hopefully I'll see you guys all next month, and look out for tomorrow's video will be on Emma Haynes. It's a video on her withdrawal injury from benzodiazapines and her injury, benzo-induced neurological dysfunction that she unfortunately ended up enduring, but also is a good story of hope and recovery. So hopefully you guys will find that helpful as well. So take care. Bye-bye.